औज़ुबिल्लाहिमिनश्शैतानिर्रजीम बिस्मिल्लाहिर्रहमानिर्रहीम। रिस्पेक्टेड लिसनर्स, आपको मालूम है कि आप लोगों की गाइडेंस के लिए FCPS पीडियाट्रिक्स पार्ट 2 क्लिनिकल एग्ज़ाम्स के लिए मैंने एक सिलसिला शुरू किया है, जिसमें मैं आप लोगों से पहले हिस्ट्री की बात की, अभी शॉर्ट केसेस की बात हो रही है। और शॉर्ट केस में जो आज का टॉपिक है वो कि अहम टॉपिक है, कॉमन डिजीज़ है और आपके एग्ज़ाम में आ सकती है। तो स्टार्ट करने से पहले एक छोटी सी बात कि आपको कंटिन्यूस 5 डेज़ अ वीक मिनिमम वर्क करना चाहिए। इट्स अ कंटिन्यूस एफर्ट्स, सो बी लाइक अ रिवर, फ्लो लाइक अ रिवर। तो आज का जो टॉपिक है मोस्टली वो है बोइंग ऑफ लेग्स होगा। इसमें जो आपको कमांड मिल सकी है वो GPE की मिलेगी या रेलेवेंट की मिलेगी। And it will be visible at just general look the child is bowing. So you start with introduction and consent, exposure. The child will be in single shot depending upon the weather condition. You must tell the examiner, followed by the hand sanitization. Then start with the general look, whether the child is sick or well looking, it's his new or her nutrition status, respiratory distress, and cyanosis at rest, dysmorphic and diagnostic features. Then check the vitals. Put thermometer in armpit at the start of the examination. In the meanwhile, check pulse and respiratory rate, or you can do it later during examination from hand to foot. Then from that onward, because it's a GPE, so you must not forget to do the complete GPE. So first the vitals, then you do the anthropometry, you check the height, then you check the upper and lower segment. The increase ratio in case of upper segment is bigger than the lower segment, and the ratio is increased in case of skeletal dysplasias and rickets because of disproportionately short limbs. Then OFC, large head in rickets and achondroplasia. Then you check weight, decrease in malnourished. If increase, consider Blount's disease. If the child is short, do the maneuvers for the short stages, such as the observations, measurements, and maneuvers. We will do the short case of short stage later. Then you check the gait, as in the last video I told you about the gait. You make the child walk on a straight line, then toes and heels, fog, reverse fog, 1 foot squat. And to rule out the proximal muscle weakness or wasting, you do the Goverstern. Then you look for the bowings of leg and knock knees. So this is a pictorial representation that is showing the disproportionately short stature in terms of, like in A, you see that the kids have disproportionately short limbs. Then you start, after doing this, you start from the hand. First check the wrist widening, pallor in chronic renal failure, chronic kidney disease, malnutrition, respiratory rate, pulse or respiratory rate if you have not done before, touch for the temperature, put thermometer in armpit. Then you in the arms check the blood pressure if you have time, mid-arm circumference for the malnutrition. BCG scar and epitrochlear nodes, sorry for the mistake, head. Then you check the FOC, craniotabes, large fontanelles, alopecia areata that is present in vitamin D dependent type 2 rickets. So this is alopecia areata. As you can take temperature here also. Then you look at the eyes for vitamin A deficiency. These are the bitoid spots, like then conjunctival pallor for malnutrition and CKD, jaundice, hepatic rickets. Then you check the mouth for vitamin B12 deficiency, tongue, glossitis, gum, vitamin C deficiency. So this is a tongue glossitis. If you have seen this, you can easily make it out. After that, you go to the chest and check the Harrison sulcus, pigeon chest, rhaetic rosary, or scorbutic rosary. So these are the chest observation findings. This is the Harrison sulcus followed by the rhaetic rosary and pigeon chest. After that, you check auscultate chest for infection, loss of fat soluble vitamins in the cystic fibrosis. Then abdomen, pot belly, hepatomegaly for hepatic rickets, skin for petechiae and bruises. In spine, gibbous and achondroplasia, kyphoscoliosis and rickets. So the gibbous or kyphoscoliosis can be present in the rickets or achondroplasia. Then at the end of the examination, you just say that I want to plot height, weight, and FOC on centile charts and take blood pressure and do fundoscopy. So I have made a hypothetical description. Before that, going to hypothetical description, I tell you that this is just the guidelines. Remember, if it is a GP short case, you must do the must not forget to take the vitals, anthropometry, and general science, and then the relevant. So first priority is to do the vitals, anthropometry, and the general science. If you miss this, then it is taken as negative. So I have made an hypothetical description. Assalamu alaikum, sir or madam. I have just examined that a year old child who is sick looking, undernourished child without obvious respiratory distress at rest and cyanosis. There is no jaundice or diagnostic dysmorphic facies. He was conscious and cooperative during my examination. His height is 100 centimeter with upper segment to lower segment ratio of 1.5, FOC of 58 centimeter and weight of 15 kg. He has disproportionate short stature with short limbs. There is bowing of legs and knock knees. His pulse is 100 per minute, respiratory rate of 20 per minute, and is afebrile to touch. There is no pallor, clubbing, wrist swelling, and absent BCG scar. There is no alopecia, conjunctival pallor, and scleral icterus. There was no hearing aid, the tongue was normal, there was no angular cheilitis, no rachitic rosary, Harrison sulcus, or scorbutic rosary. There is no visceromegaly and no signs of vitamin A, D, E, K deficiency. I want to take blood pressure, plot height, weight, and FOC on centile charts and do fundoscopy. So the differential diagnosis, if you come across a child with the bowing of legs, what are the differential diagnoses? So differential diagnosis depend upon the age of the child. If the child is a younger child, the first stop will be the nutrition rickets, then resistant rickets, and CKD will also be considered. While ever in older child, you must make the differences of vitamin D dependent rickets, X-linked hypophosphatemic rickets. It primarily involves the lower limbs, CKD, Blount disease, or skeletal dysplasia, distal tubular acidosis. The examiner may ask you a question about the difference between rachitic and scorbutic rosary. Scorbutic rosary is a tender with the gum findings, while rachitic rosary is non-tender. Rachitic rosary are prominent costochondral junctions due to increased osteoid, while scorbutic rosary are sharp curves of ribs because of periosteal elevation. So this is the table. You must recognize that is a different type of rickets. In that you must see it that in nutrition rickets, see only the difference is the calcium, parathyroid hormone, and alkaline phosphatase is increased. So alkaline phosphatase is increased in almost all type of rickets. However, phosphate is only increased in chronic kidney disease. And remember, in hypophosphatemic, hypophosphatemic rickets, there is a marked increase in urinary calcium, hypocalciuria. So these are the different table. You have to see this and memorize this table. Then the stimulus for parathyroid hormone release is decreased calcium and phosphorus. The functions of parathyroid hormone: it increases serum calcium, leaches calcium from the bone, increases absorption of calcium from the gut and kidney, decrease urinary calcium losses, decrease phosphate absorption in kidney, and resultantly increase phosphate loss. Parathyroid hormone also increases 1-alpha hydroxylase activity, the reason why it is raised in kidney failure. Infant requires 2 hours per week of head exposure to sunlight or 30 minutes per week of total body exposure. 7-hydroxycholesterol in skin is converted by ultraviolet light to vitamin D3, which is taken to liver for 25 hydroxylation and then in kidney for 1 hydroxylation. D2 is ergocholecalciferol and D3 is cholecalciferol. There is no vitamin D1. Management depends upon the cause of rickets. In case of nutrition rickets, there are two regimens. One is the Strauss therapy or high dose therapy, in which you give 300,000 to 600,000 units of vitamin D3 either orally or intramuscular in 2 to 4 divided doses, or 2,000 to 5,000 international units per day or 4 to 6 weeks. Each regimen is followed by daily vitamin D3 intake in a dose of 400 international units per day for children less than 1 year old and 600 international units per day for greater than 1 year old as multivitamin. Ensure adequate calcium and phosphorus in diet by formula milk or dairy products. IV calcium for tetany followed by oral calcium, which is then tapered off over 2 to 6 weeks. Calcitriol is 0.05 microgram can be given. Calcium is 1000 milligram daily oral. Vitamin D resistant rickets is considered if no radiological evidence of healing rickets after 2 megadoses of vitamin D. Vitamin D deficient rickets, you can give calcitriol 0.25 to 2 microgram per kg per day. Dose of calcitriol is adjusted to maintain low normal serum calcium, normal phosphorus, high parathyroid hormone, and target calcium excretion should be less than 4 mg per kg per day. Vitamin D dependent type 2 rickets, all patients should be given 3 to 6 month trials of high dose of vitamin D and oral calcium. Calcitriol 2 mg per day to 50 to 60 mg per day. Calcium is given in 1 to 3 gram per day. X-linked hypophosphatemic rickets. 1 to 3 gram elemental phosphorus in 4 to 5 divided doses. Calcitriol 30 to 70 nanogram per kg per day in 2 to 3 divided doses. Monitor with alkaline phosphatase. In children with short stature, growth hormone can be given. Hereditary hypophosphatemic ricket with hypercalciuria 1 to 3 gram of elemental phosphorus in 4 to 5 divided doses. Phosphorus causes diarrhea, so it has to be divided equally. So treatment of decreased phosphorus decreases serum level of 125 hydroxylase and correct hypercalciuria. Response to treatment is excellent with the resolution of pain and weakness and radiological evidence of rickets. So the short review of the pathophysiology of X-linked hypophosphatemic rickets or autosomal dominant hypophosphatemic rickets. Mutation in FAX gene, so there is increased level of fibroblast growth factor 23 phosphatonin, and FGF causes decreased reabsorption of phosphorus in proximal convoluted tubule, so decreased phosphorus in serum and decreased 1-alpha hydroxylase with decreased 125 vitamin D3. Decreased phosphorus normally upregulates 1-alpha hydroxylase, but these patients have normal or decreased level of vitamin D3. So thank you very much for your listening, and this is, I tell you, this is general, just the scheme. You can add on it, you can improve this thing, but the main aim is that you reach to at least to a differential diagnosis. So I finish this by praying that may Allah be our guide, our helper and our protector. Best wishes. Allah Hafiz.